Hi, I'm Rachel Jantia, Geriatric Medicine faculty at McGovern Medical School, and this is the ICARE Geriatrics module, the 4 M's of age-friendly health systems, what matters most. Our objectives are to explain why what matters most should drive healthcare-related decision-making for older adults, to help clients explore what matters most to them as they age, and to share resources for clients interested in talking to their healthcare providers about what matters most to them and about creating advanced directives to ensure their wishes are carried out. When it comes to healthcare-related decision-making in older adults, we have to balance multiple factors to ensure that the benefits do in fact outweigh the risks for any particular intervention, and that intervention's outcomes align with what matters most for the older adult. Why is this? First, older adult healthcare tends to have a greater complexity. Almost 80% of older adults have at least 2 chronic conditions, and many have more than this. In addition, you can't take for granted that the time to benefit for any particular intervention is going to apply to a particular person. For example, if there is an intervention that reduces someone's 10-year risk of stroke, but someone is not expected to live for the next 10 years, they may not benefit from this intervention, but they may be incurring the risk of the intervention at the same time, and so the benefits do not outweigh the risks. In addition, we know that older adults have a tendency to experience higher rates of harm compared to younger adults for any particular intervention. That includes higher rates of healthcare-related harm, delays in care, and discoordination of care. And in addition to this, personal goals and preferences are different from one person to the next. We have to take into account what matters most to a patient and their family, and this should directly determine how care is provided. This requires a conversation about what matters most to the person. And I'm going to give you an example of what this looks like in practice, or how this might apply. So I want you to imagine an 82-year-old woman who has high blood pressure, diabetes, high cholesterol, and chronic kidney disease, who is coming in to her healthcare provider to follow up on these chronic issues. She has high blood pressure with a reading today of 145/90, and hemoglobin A1C of 8, and a total cholesterol level of 235. For those who are not familiar with these numbers and these conditions, these would generally be considered over goal for these conditions for most adults. So how would this healthcare provider advise? Well, most instinct would be to say, we need to have better control of your blood pressure, diabetes, and cholesterol. Well, if this woman told you that what matters most to her is to live as long as possible without complications from these conditions and to prevent progression of her kidney disease, that would probably be the right call, assuming that the benefits in her case outweigh the risks. However, what if the woman told you that she's experiencing dizziness and falls and has had to limit her social interaction because of them? And then she told you that what actually matters most to her is maintaining her functional ability and being able to leave her house to do the things that she enjoys in the time that she has remaining in her life. In this case, you can see that it might not be the right call, because it turns out that in older adults, tighter blood pressure and A1C goals might actually further increase the risk of falls due to low blood pressure and low blood sugar risk. In addition, adding new medications might increase the risk of adverse drug events, which in turn then increase the risk of hospitalization and further physical decline, which is the opposite of what her goal is. Suddenly, the benefits don't so clearly outweigh the risks when the goal changes. We cannot assume that every older adult has the same goal or that they have the same goal as you do for them. This case exemplifies the need to tailor care to what matters most for each individual. So how do we understand what matters most to a particular person? These are some questions that can help you understand a person's individual priorities and to help them think about them. What is most important to you today? What is it that brings you joy in life? What are some goals that you hope to achieve in the next 6 months or before your next birthday? What else would you want your provider to know about you as a person? And then questions that they can think about to help their providers understand the types of treatment that would be aligned with goals and preferences. You can encourage your client to think about these questions. What are your most important goals now and as you think about your future health? What concerns you the most when you think about your health and the healthcare in the future? What are your most important goals if your health situation were to worsen? And what are the things about your healthcare today that you do not think are actually helping you? All right. So once we understand what matters most, it's also important to encourage our clients to establish advanced directives. Advanced directives communicate a person's wishes about their end-of-life care to friends, family, and healthcare professionals. In the event that they are unable to communicate those things themselves at the end of life. Those who complete an advanced directive are more likely to receive care that is consistent with their personal preferences, and yet more than half of older Americans have not completed an advanced directive. So what do we mean by advanced directives? The first one is called, these are the three most common ones, I should say. The first is called a medical power of attorney. This is an official written assignment of a surrogate decision maker in the event that a person loses capacity for decision making. It's a notarized document, and the older person essentially says, this is the person I would want to make decisions on my behalf if I could not make them for myself. The second type is called a living will. It's a little bit more elaborate. It includes more. It is also a written statement of a person's wishes regarding their medical care under specific circumstances in the event that the person loses capacity to make statements about what they would want in that moment. Examples include, would you want to receive CPR or life support using a ventilator, dialysis, artificial hydration and nutrition, for example, by feeding tube. This document may also designate a surrogate decision maker and go a step further to specify that surrogate's power. Does that surrogate have permission to override what your wishes were in that document? Or do they only have the power to make decisions that are not specifically specified in this document? This is also notarized and often prepared by an attorney, but does not have to be. And then finally, there's something called a do not resuscitate. This is a directive to your physician and other healthcare professionals about whether you want to receive CPR and life support using a ventilator in the event of cardiac arrest or respiratory failure. In Texas, CPR is the default treatment in the event of cardiac arrest. Therefore, those who want to have a natural death without CPR must specify this, and this form is a great way to do that. This form also must be notarized, and each of these forms is available in the resource list that we've given to you to share with your client. So finally, in conclusion, how do we align care with what matters most? Number one, you encourage your clients to communicate their values and health priorities with their healthcare providers. And number two, encourage them to document and share their advanced directives with their loved ones and healthcare providers.